Hello everyone, Anthony here from Succeeding in Nursing School, and today we're going to have our first video on pharmacology, starting with two classes of anti-hypertensives that I've had the most questions on from students that I tutor, these being calcium channel blockers and beta blockers. In this video I'm going to discuss important drugs in each class, how these drugs work, specific side effects to watch for, and indications of use for them. Due to the nature of these drugs, I could easily spend probably 20 minutes discussing each individual class, so I'm going to try to keep this information condensed and relevant to what's going to be present to you in theory and for clinical. Starting with calcium channel blockers, these drugs work by inhibiting calcium channels in vascular smooth muscle and cardiac tissue. By inhibiting these calcium channels, the influx of calcium in the muscle cells is decreased, resulting in vasodilation of the vessels. In myocardial cells in particular, there are certain L-type calcium channels that are responsible for myocardial force, so blocking these channels decreases myocardial force, or acts as a negative inotrope. It decreases heart rate, which acts as a negative chronotrope, and it's going to decrease the conduction speed throughout the heart, which is going to act as a negative dromotrope. Due to these properties, calcium channel blockers are mainly used for the treatment of hypertension, angina, and certain drugs are used for the treatment of supraventricular tachycardias. Calcium channel blockers technically have three groups that they can be placed in, although most people are going to distinguish them between two different types. So there's going to be dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. DHP calcium channel blockers have a stronger affinity and selectivity for vascular smooth muscle, making them the preferred choice for treatment of hypertension. Because of their affinity for vascular smooth muscle, it can cause a pronounced vasodilation, which may end up resulting in sympathetic stimulation from the body, which can cause reflex tachycardia, offsetting any of the benefits of the drug. There are extended release formulas that can also be used for treatment of angina that have a lower chance of causing this kind of reflex tachycardia. So dihydropyridine calcium channel blockers, you're more worried about reflex tachycardia, which can increase myocardial oxygen demand, which can actually worsen angina. So typically with these kind of drugs, you're going to avoid them. So any kind of side effects to look for with these would be your side effects for hypotension. So having hypotension, any kind of orthostatics, flushing, headache, those kind of symptoms. For non-dihydropyridines or NDHP drugs, there's two drugs that comprise this class. There's verapamil, which is Verilan, and dotiazem, which is Cardizem. Verapamil is more selective for cardiac tissue, which makes it a preferred agent for treatment of angina and for certain arrhythmias. Dotiazem is kind of like the middle ground between verapamil and the DHP class. It does have more pronounced cardiac affinity than the DHP class, but it also has, more vascular selectivity than verapamil does. So if you're using a DHP and you had a patient who ended up getting reflex tachycardia, but you still need the benefits of a calcium channel blocker, you could try dotiazem, as it has a lower risk of causing the sympathetic stimulation resulting in reflex tachycardia. Or if you have a patient on verapamil, you're treating them for angina, and now they need some kind of anti-hypertensive medication that verapamil can't benefit them from, you can switch them over to dotiazem and see if their angina is managed with that, while also controlling their hypertension. For DHP drugs, they have a very specific ending to them, which makes them very easy to notice. They have a -pine ending. So your most common ones are going to be amlodipine or Norvasc, nifedipine or Procardia, and nicardipine, which is Cardine. Not to jump back and forth, but for your non-dihydropyridines, the signs and symptoms you're going to look for with these drugs are more related to the cardiac effects that they have. So you may see some kind of transient AV block, that would be the most common type, or bradycardia. It's going to be the most common side effects you would experience from those two kind of drugs. Moving on to beta blockers, this is another popular class of antihypertensive medications that also has a wide variety of use. Beta blockers are easy to identify as they have a signature little OLOL or LOL ending to them. Most common agents in this are labetalol, which is Norvidine, metoprolol, which is arguably the most common one, Lopressor, and propranolol, which is Inderal. So beta blockers work by inhibiting stimulation of the beta-adrenergic receptors in the body, with a relative selectivity for cardiac tissue, or beta-1 receptors. There's 3 different types of beta receptors in the body: beta 1, which is found in heart tissue; beta 2, which is found throughout the body, mainly in the lungs, gut, peripheral smooth muscle, and pancreas; and there's beta 3, which is found in adipose tissue. So we're going to focus on the beta 1 and 2 receptors here. So depending on the drug in the class, whether it's a first generation or a second generation beta blocker, it will have a higher selectivity for these beta 1 receptors found in the heart. Metoprolol is one of these drugs, which is why it is arguably the most common beta blocker used. So beta receptors in the heart are responsible for controlling the force of contraction, rate of contraction, and speed of conduction through the heart through the sympathetic stimulation. By blocking these receptors from sympathetic stimulation, it results in a decreased inotropic effect and a decreased chronotropic effect, resulting in decreased myocardial oxygen demand. Beta blockers have many indications as a result of this, including treatment of hypertension, although they're more of a second or third line kind of treatment option, just because they have more pronounced side effects than some of the other first line indicators like thiazide diuretics or even ACE inhibitors. They can also be used for angina, but again, there's better options for it if possible. They can be used as antiarrhythmics. Mainly, you're going to see probably labetalol being used for that, although I guess you could see Lopressor as well. They're used for MIs, and they're also used in the treatment of heart failure. But as discussed in that heart failure episode we had, beta blockers are contraindicated during the acute phase of heart failure, and they need to be used sparingly, as you can further decrease the inotropic effects of the heart, so it's not really actually able to contract, and you can send a person into having them develop an MI. Beta blockers are commonly used during a hypertensive crisis, especially if the patient is tachycardic. If the patient's normal cardiac, then a drug like Norvasc or Procardia is actually going to be preferred. This reasoning is because you're going to slow down the heart rate with a beta blocker, and you're going to slow down, or you're going to decrease the blood pressure. Whereas if they already have a normal heart rate, you don't really want to run the risk of causing them to be bradycardic with hypertension. Most common side effects from beta blockers are going to result from impairing the sympathetic response, which includes decreased exercise capacity. You can cause heart failure, like I said, hypotension, and transient AV block due to decreasing the conduction speed through the heart. Depending on the beta selectivity also, beta blockers may cause bronchospasm or bronchoconstriction, as they can cause a blockade of the beta 2 receptors in the bronchioles. Therefore, for patients with asthma or COPD, beta blockers are actually contraindicated. You may still see them be used. If they are used, they're going to be monitored very closely, and it's going to be a lower dose. Beta blockers can also mask tachycardia in diabetics. That would be a sign of hypoglycemia and other hypoglycemic symptoms. So for diabetics, it needs to be used cautiously if they're going to be included in the regimen. As of now, this is going to be all I will talk about with these drugs. If it's warranted or asked for in the comments, I can make a more detailed description video about any kind of drug in this, either calcium channel blockers or beta blockers. Until then, thank you all for watching. Go ahead and like the video and subscribe if you want to see more, and leave any comments in the description about what other kind of videos you would like to see. Thank you.